in pancreatic cancer, right, the 5-year survival rate's like reported to be about 11.5% for all comers, which means that there's a lot of room for improvement. And unfortunately, in clinical practice as it exists right now, there are no tools, biomarkers or otherwise, that really enable earlier detection of pancreatic cancer. But the other part of it too is like these biomarkers that do exist, for example, CA19-9, really have some value once the diagnosis is in play, not necessarily on the earlier side. So there's really a clinical unmet need here, right, to find a tool that can actually detect cancer early in pancreas, all while improving the lives of these patients. Because if you can get into a surgical intervention earlier, maybe options for therapy, chemotherapy, and radiation might also help as well. So all these things kind of combined, that's why we have our tool for biological dynamics for an early cancer detection. I think what's really cool about biological dynamics is that we've got a proprietary technology platform that enables the use of isolating exosomes. And so this was developed years ago out of UCSD, the technology in itself. But what we've been able to really do is take this technology and really fortify it to isolate these exosomes. So what you need is really low input volume. So we're looking at about 280 microliters of plasma is what we're using in this study. Plasma just essentially means that the blood that we take from patients are spun down, and then that we take the plasma portion of that. So we only really need a minimum input. When we feed it through our technology actually has a better yield than other standard of care methods, such as ultracentrifugation, which is gold standard. And we've found that using our technology in isolating exosomes actually enriches the exosomes such that we don't have as much background noise and we have a better purity. And when we do that, we can take these exosomes and then we feed it into a multiplex ELISA, which is just essentially to quantify the amount of exosomes. And then from there, we can use a machine learning algorithm to understand how a performance curve or a ROC curve can be analyzed to predict the score of a high likelihood or a low likelihood of developing pancreatic cancer. So right now, this locked algorithm is based out of 7 protein biomarkers, which essentially means that we are measuring the proteins that are expressed on the surface of the exosomes or the extracellular vesicles. And within that, and also within the literature, there are these biomarkers include CA19-9, CA153, prolactin, leptin, ferritin, SHER3, and FGF2 as well. I believe those are the 7 biomarkers. And in terms of machine learning, the machine learning algorithm first takes the 52 biomarkers that are on this multiplex ELISA. And then what we do is we select and feature select for the most optimum biomarkers that gives us the best balance between sensitivity and specificity. This is how we landed on our locked algorithm of 7 protein biosignatures that is based on both our training set and our validation set. So our training set, which consists of about 650 patients, of those, 105 patients were early stage pancreatic cancer patients, stages 1 and 2. Basically, these were the resectable, borderline resectable patients by staging, compared it to 545 patient controls. Our AUC yielded about a 97.1% there, which is pretty phenomenal. And our overall sensitivity was about a 93.3%, and our overall specificity was about a 91%. Now, that was just a training cohort. No training cohort is complete without a testing of an independent cohort. And that's what a validation study is. So when we did the validation study, subsequently after the training study, this was tested on about 113 patients, of which 30 of those patients were cases, so documented early stages 1 and 2 pancreatic cancer, versus I think about 83 of the rest of were controls. The important thing in this cohort was that we included some benign disease. So about 11 of those patients were about acute or chronic pancreatitis patients. Overall sensitivity on the validation cohort was about 90%, and then a specificity of about 92.8%, so around 93%. So, which basically tells us that the validation cohort upheld the training set as well. I think this is the start of a really great journey for both the exosome science space, our technology platform, and our application of it in terms of pancreatic disease. And so actually what we're doing now is running an X-Illuminate registry trial. I'm the principal investigator for biological dynamics in that. We're pretty well into that trial right now, where we will need about 1,000 to 5,000 subjects. But essentially what we are doing is prospectively collecting blood on patients of high risk that have a tendency to develop pancreatic cancer. And these basically include cohorts such as pancreatitis patients, acute or chronic, hereditary pancreatitis, genetic mutation patients, patients with a strong family history. And then of particular interest for us are these IPMNs, which are basically the cysts on the pancreas. There's a huge unmet need with the cysts, particularly, not only just the high-risk group, but the cysts, where that we as clinical providers really don't understand before surgery if these patients really are at high risk versus these patients are really at low risk. So can we develop a tool for surgeons and gastroenterologists and providers alike, where we can differentiate between high-grade dysplasia and low-grade dysplasia, so that patients that need surgery can get surgery, and the patients that may benefit from a watch and wait protocol, we can get those patients funneled into the accurate kind of clinical plan care, excuse me.